So imagine this. What actually happens when the digital heartbeat of a hospital just stops? Picture a busy, bustling medical facility. Monitors are beeping, clinical staff are rushing around, and vital patient info is flowing everywhere. And then suddenly, the screens go black. Maybe a network switch fails, or, a ransomware attack locks down the entire hospital information system. The stakes in this environment instantly skyrocket in a way you literally do not see in any other industry.
The harsh reality we have to face is that in healthcare, disruption places patients at immediate risk. If a normal business goes down, right, they might face delayed sales or a dip in revenue. But a hospital? You can't just send ICU patients home because the servers crashed. Emergency treatments absolutely cannot wait for an IT reboot. An outage delays diagnoses, interrupts vital treatments, compromises medication safety, and straight up puts human lives on the line.
Okay, let's look at our agenda. We're going to cover 1. Disruption in healthcare services, 2. BCM versus BCP explained, 3. Assessing the business impact, 4. Clinical strategies and workarounds, and finally, 5. The 90-day continuity roadmap. This is our step-by-step guide to diagnose the problem and build a truly resilient system.
Let's dive right into Section 1, Disruption in Healthcare Services, Dependencies and Risks. We really need to recognize just how uniquely fragile uninterrupted hospital care truly is.
It's all about the domino effect. Take an operating theater, for instance. You might have stable electricity and a fully prepped surgeon ready to go, which is great. But if your laboratory information system is locked offline, you can't get critical test results. No radiology system, no imaging. If you can't pull up digital patient consent forms, or verify blood products, or even track sterile instruments, that surgery just cannot proceed. You can't look at departments in a vacuum. You absolutely have to look at the entire patient care pathway.
Moving on to Section 2, BCM versus BCP explained, understanding terms. Let's open our diagnostic toolkit here and clear up some of the cognitive load around this industry jargon.
There's a really important contrast we need to make here. Business continuity management, or BCM, is the overall management process. It's active, it's led by leadership, and it's continuously used to identify risks, train staff, and improve resilience. On the flip side, a business continuity plan, the BCP, is simply the specific, documented response plan that comes out of that BCM process. Basically, BCM is the living, breathing program, while the BCP is just the instruction manual you use during a crisis.
I absolutely love this quote from our source material because it hits the nail right on the head. One of the most common mistakes is asking the IT department to prepare the entire BCP alone. I mean, it's kind of funny to picture an IT professional trying to dictate complex nursing workflows or surgical schedules, right? IT might own the servers and networks, for sure, but they do not own patient registration or clinical decisions. Continuity has to be driven from the very top, by hospital directors, not just by tech support.
All right, Section 3, Assessing the Business Impact, Prioritizing Services. This is where we figure out how to triage everything and prioritize what actively saves lives over what just handles administration.
This wonderfully simple business impact analysis matrix perfectly illustrates how to prioritize when things hit the fan. Look at emergency registration. It has an immediate target recovery time because any delay directly impacts treatment. Pharmacy dispensing gives you maybe 15 minutes before unsafe medication situations start popping up. But check out finance reporting at the bottom. Sure, it causes an admin delay, but it can safely wait 24 hours using offline records. If you label every single department as critical, well, you haven't actually prioritized anything.
So let's define a vital technical term here. Recovery Time Objective, or RTO. This is simply the targeted period within which a disrupted service should be restored. But here's the massive catch. Your RTO has to be shorter than your maximum tolerable downtime. If you aim to restore a service at the exact minute where patient safety becomes unacceptable, you're leaving yourself zero margin for error. And let's be real, in a crisis, complications are practically a guarantee. You need that buffer.
Let's transition to Section 4, Clinical Strategies and Workarounds, Strategies for Downtime. We're looking at the practical steps that bridge the gap when the digital systems fail.
We break down activation into 3 clear steps. Step 1 is a local disruption, like a single department losing its network connection. Step 2 is a significant operational disruption, where multiple departments or systems go offline. And Step 3 is a major organizational crisis, meaning patient safety or the hospital's reputation is actively threatened. Staff need to know these levels inside and out, so they immediately recognize when a minor glitch escalates into a full-blown event that requires formal authority to step in.
This brings us to the essential downtime kit. We're talking manual registration forms, clinical continuation sheets, medication order forms, temporary patient registers, and departmental action cards. These are literal lifesavers when digital systems vanish. But you know what's crazy? Our source points out a classic tragic mistake: locking these kits in a manager's office. If that office is locked after hours when a crisis hits, the kit is completely useless. They absolutely must be sealed, version-controlled, and accessible on the floor 24/7.
Okay, so how do we actually pull this off? Section 5, the 90-day continuity roadmap, building the plan. This is the crucial point where we take all this overwhelming compliance stuff and turn it into an urgent, actionable roadmap.
We're breaking this down into 3 fast-paced, 30-day sprints. 30 days to establish the foundation, 60 days to analyze and develop, and 90 days to train and test. The clock is ticking, so let's jump in and see what happens in each phase.
Sprint 1, days 1 to 30, is all about the foundation. You need to get executive approval, appoint a steering committee, and strictly define your scope. And I mean from the operating theaters right down to the ambulance and laundry services. You have to know exactly what is covered, because if you don't define the scope, departments will just assume someone else is handling a dependency, and a critical vulnerability gets completely ignored.
Then we hit days 31 to 60. This is the analyze and develop phase, where the real heavy lifting happens. You conduct those departmental business impact analyses, establish your recovery targets, and standardize your forms. But most importantly, you prepare departmental playbooks and actually assemble those downtime kits. A generic 80-page hospital-wide manual is totally useless in an emergency. Every department needs its own short, practical playbook with clear checklists.
Finally, days 61 to 90, train and test. Look, a plan that has never been tested is literally just a theoretical document. You absolutely have to brief your staff, run tabletop exercises for things like ransomware, and physically test your manual workflows. If your test doesn't reveal any gaps or require any corrective actions, I promise you the test just wasn't hard enough. Functional exercises are completely non-negotiable.
Let's move on to our final phase, Section 6, Sustaining the Lifeline Recovery Process. We really need to talk about what happens right after the IT department finally gets the systems back online.
Here's the thing about the recovery and reconciliation process: confirming the system is stable and authorizing a return to normal is just the beginning. A technical boot-up means absolutely nothing if hours of manual paper records aren't meticulously entered back into the system. You have to reconcile medication orders, verify patient transfers, and officially sign off on that reconciliation. Nursing and pharmacy teams might need hours just to verify data integrity. The incident is not over until this entire process is done.
So that brings us to the ultimate question. If the screens go black today, does your staff know exactly what to do? Or will they just be guessing in the dark? Because the real measure of a continuity plan isn't how pretty the binder looks. It's whether a nurse or a doctor can actually use it during a highly stressful incident without second guessing. I highly encourage you to evaluate your own facility's readiness today.